Hi guys, welcome to this quick virtual lesson on temporary pacemakers. So who needs a stinking pacemaker anyway? What are the indications for it? Patients who have bradyarrhythmias, such as symptomatic sinus bradycardia, patients who have brady-tachy syndrome, where they're slow, they're fast, they're slow, they're fast. Third degree or second degree type 2 AV block. Patients don't typically tolerate brady-tachy syndrome too well. They don't tolerate third degree or second degree type 2 very well. They'll have hypotension. They can have altered level of consciousness, things like these. So those patients will get a pacemaker. They can have pacemakers for tachyarrhythmias, for overdrive pacing, where they will try and pace the patient where it will compete with their intrinsic rate and eventually overtake it. AFib or a flutter, SVT, junctional tachycardia, these kinds of rhythms. They also can do it prophylactically, such as prior to anesthesia, especially if they're concerned about the patient who has an existing heart block. They can do it as a bridge to a permanent pacemaker. During EP studies, they can do it prior to the induction of arrhythmias. And they also do it during cardiac surgery due to their risk for postoperative arrhythmias, especially they'll have with the valves, they can be at risk for having blocks or things like that. And with your patient who's having just a cabbage, they are at risk for atrial fibrillation. And so with your valve patients, when you do surgery on the heart, they can have some swelling that causes problems with the conduction system, and so sometimes they'll not only get slow, they won't have any underlying electrical activity at all, and so they will put in a temporary pacer to help with that. So the parts of a pacemaker, the bridging cable is, if you look on this picture, you'll see a green dot. This is the device that we use to secure the electrodes to the pacemaker generator. You can also, if you didn't have a bridging cable, there's also holes on the top of the generator that will allow you to plug your electrodes directly into them. This is a temporary pacemaker. This is what the one we use looks like. It's a Medtronic product. It's battery operated. It uses a 9-volt battery, and it's what produces the electrical current to stimulate the heart. You then have electrodes or leads that carry the electrical stimulus to the heart, and here's what those look like. There are types of temporary pacemaker generators, two types. You have a single chamber and dual chamber. Obviously the single chamber, they have one port for connecting the bridging cable and one set of controls. So they will pace only the atrium or only the ventricle, but not both at the same time. Whereas with your dual chamber, you will have two ports that can accommodate two bridging cables, and you can pace both the atrium and the ventricles at, or they can be set up to function as a single chamber as well. Your single chamber pacemakers, they allow the clinician to set the pacemaker rate, set the level of the electrical energy delivered to the heart, and also how sensitive the pacemaker is to the patient's intrinsic or their own natural cardiac rhythm. Dual chamber pacemakers allow the clinician to set the pacemaker rate. They allow the level of electrical energy delivered to the atrium and the level of electrical energy delivered to the ventricle, both to be adjusted. And you can also tell the generator with a dual chamber how sensitive the pacemaker is to these chambers, to two chambers intrinsic activity, There are 4 types of temporary pacemakers. Transcutaneous is where you have the pads hooked up to our defibrillator, which is the LifePak 20. Then there's epicardial wires, transthoracic, or transvenous. So again, transcutaneous is through the skin. There are external electrodes that deliver electrical stimulus to the heart via patches. They can be placed on the right side of the sternum beneath the clavicle and on the left chest wall near the apex of the heart. And if you forget where you're supposed to put your patches, most of the patches on the packages actually, or on the actual patches, have a diagram on there that show you where to put them. There is an alternative though. You can do what we call the sandwich method. So at the 4th, 5th intercostal mid-clavicular line, you can put it anteriorly and posteriorly. The transcutaneous pacing method only paces the ventricle, and it's usually used or reserved for cases of emergency. Epicardial wires, they're the ones that the CV surgeons will place during cardiac surgery. They are attached to your epicardial surface of the right atrium and the right ventricle with pacing wires that exit the chest wall, so when it comes time to get them out, they just usually pull them out. And then there is transvenous pacemakers. So pacing occurs via 1 or 2 electrodes. They can either be placed in the right atrium, into the right ventricle. They're usually through a central vein. So anywhere that you would have a central line, you could put a transvenous pacer, including jugular, subclavian, femoral, or brachial. Depending on the leads, they can be placed both atrial and ventricular. But usually what I have seen is they'll be ventricularly pacing the patient only, but they do have a capability where they could pace both. It can be inserted at the bedside, or it can be done in the cath lab under fluoral. It just probably depends on how emergent the situation is. There's also pacing pulmonary artery catheters or pacing swans available to use with the transvenous approach. Transthoracic, this is not one that we see very frequently. It's only used for ventricularly pacing the patient. It's usually placed through a long pericardial needle. They go just below the xiphoid process directly into the right ventricle. This is usually emergent, and it's used as the last ditch effort after all other methods have been tried. So I kind of said something about this earlier, but no wire, no problem. A bridging cable serves as a bridge between the generator and the electrodes, and it really does a great job if you tighten the screws on the side enough of tightening down and securing those electrodes. But you know, the bridging cable is just similar to an extension cord, so at the same time it provides a secure connection. If you don't have a bridging cable, you can plug the electrodes directly into the end of the pacemaker generator. Soon as you have the cable, use it. There's no way to tighten electrodes directly into the pacemaker, so the bridging cable is a lot more secure. So pacing is just simply the firing of electrical energy by the generator. Each time the energy is fired, the pacing light will illuminate on the pacing generator. And what you'll see on your monitor is pacing spikes. Having pacing spikes on the EKG tracing does not ensure that you will have a heart stimulated by electrical impulse. It just simply means that the electricity was generated by the pacemaker. So basically, you can have pacing spikes, or you can have that electrical activity up on that monitor, but the patient can be PEA, pulseless electrical activity, even with a pacemaker. So they got electricity, they have electrical activity, but it's not really doing the patient any good or benefit. So energy, or electricity fired by the pacemaker, is called output. It's usually measured in terms of milliamps or MAs. The milliamps generally range from low 0.1 milliamps to a maximum of 20 or 25, depending on the generator you're using. The higher the value of milliamps, the stronger the impulse delivered to the myocardium. So you always want to use the least amount of output that you can use to generate electrical activity in that patient. As you look at the picture, I have, this is what our Medtronic looks like, and I have arrows on the atrial output and the ventricular output. So what does having capture mean? Well, having capture, the pacemaker generator has to fire electricity. The electrode must deliver the electrical impulse to the atrium and the ventricle, and the chamber must respond to the electrical stimulus. So having capture, seen on the EKG tracing as having a spike immediately followed either by a P wave or a QRS complex, depending on which chamber you're trying to pace. If you're trying to pace your atrium, then you want to see the spike before the P wave. If you're trying to pace your ventricles, you want to see the spike before the QRS complex. And if you're trying to pace both chambers, you should see a spike before your P wave and a spike before your QRS complex. In addition to looking at what's on the monitor, you can look at clinical signs such as improved level of consciousness, skin is warm and dry, they have improved capillary refill, these kinds of things. If you have a patient that got the temporary pacer put in and they have an art line, then you'll see an improvement in their blood pressure with return of their atrial kick.
This patient's pacer is being placed for third-degree AV block. The next step is to prepare the pacing wire. The pacing wire should be uncoiled onto the patient. The unique features of this wire are a protective shield, which not only protects the distal tip of the pacing wire, but maintains the curvature to successfully float the pacing wire. It is important when uncoiling the pacing wire to maintain its original curvature, which is designed to facilitate entry into the right atrium. Next, the contamination shield is placed. The contamination shield needs to be placed over the pacing wire prior to floating it into the patient. The contamination shield can be placed out of the operator's way until the pacer is successfully placed. The contamination shield should be left compressed until capture is achieved. Next, the balloon is tested at the distal tip of the catheter to ensure that it inflates properly. This usually requires approximately 1.5 cc's of air. Once proper functioning of the balloon is verified, the balloon should then be deflated. At this point, the pacing wire should be inserted into the patient. Again, follow the curvature of the wire. Advance the catheter to a length of 20 centimeters and inflate the balloon. It is important to insert the catheter wire to at least the 20 centimeter mark prior to inflation to ensure that the distal end of the wire and its balloon has passed through the entire length of the cordis catheter. The valve must be turned to the locked position to maintain balloon inflation. The balloon allows the wire to float gently into place and reduce the likelihood of intimal damage. Once the balloon is inflated, the sterile operator should open the package with the adapters that connect to the distal end of the pacing wire. Once the adapters are inserted, the distal end of the catheter can be handed off to a non-sterile operator. Ports should be inserted positive to positive and negative to negative. At this time, the pacing box can be turned on. The rate should be at least as high or higher than the patient's innate rate. As the catheter is advanced, watch the monitor for pacer spikes. The output should be started at a high level, and once capture is sustained, dial back to a level in which one loses capture. Then, dial back up to a minimum output to sustain capture. Once this capture is sustained on the monitor, the contamination shield can be connected to the cordis port and the cordis secured. It is important to remember that at any time an air embolism can be introduced through an unsecured catheter. All precautions should be taken to prevent this occurrence. The sheath should connect securely to the cordis catheter. Once the sheath is secured to the cordis catheter, the entire line should be secured using 3/0 silk on a straight needle. As always, a sterile barrier is applied to reduce the incidence of infection. As with any upper central venous catheter placement, certain procedures should be followed. Obtaining a chest X-ray is necessary to assess for proper placement of the pacing wire in the right ventricle. Additionally, a chest X-ray will assess for any complications related to the central line insertion. A 12-lead EKG will show capture spikes before every QRS, ensuring proper capture. Any patient sick enough to receive a transvenous pacer requires continuous cardiac monitoring.
Here is a quick review. Arrange all necessary equipment, including the transvenous pacer kit unique with cordis catheter. Insert the catheter in the right internal jugular or left subclavian vein in sterile fashion. Insert the wire to a length of 20 centimeters. Inflate the balloon. Set pacer generator to a rate greater than the patient's. 80 is usually a good starting value. Then set the output. Starting at 5 milliamps should be sufficient. Advance the pacing wire until capture occurs. Decrease output to a minimum level to sustain capture. Then slightly dial back up to a comfortable level above this threshold. Lock the contamination shield in place. Secure the catheter firmly in place via sutures.
Okay, so when we talk about stimulation threshold, we talk about using the lowest amount of energy possible to cause your heart to respond each time an electrical impulse is fired by the pacemaker. So I kind of touched on that a little bit earlier. So what happens when you supply an excessive amount of electricity to anything over time? Well, what happens in this scenario is, one, your heart is eventually going to be resistant to that amount of electricity and require higher voltage. So if you already start out at the highest voltage, then you're not going to have anywhere to go. Or two, you're frying myocardium and you could potentially be doing damage to that patient. So it's extremely important to use the least amount of energy to require capture. Resistance to electrical impulse can develop over time. So we have to be mindful of this and use the least amount possible. So when you hear people talk about sensitivity and pacemakers, what they're talking about is the ability of the pacemaker to see the patient's intrinsic value or heart rate. When the pacemaker senses native or intrinsic cardiac activity, then the pacemaker will refrain from initiating pacing, and the sensing light of the pacemaker flashes. It will say it's sensing, but sensing and capturing are two different things. So the clinician is responsible for setting the sensitivity for each chamber being paced. So sensitivity threshold, this is adjusting the sensitivity for each chamber being paced. Sensitivity is usually measured in millivolts. The lower the millivolt value, the more sensitive the pacemaker is to intrinsic or native or the patient's own cardiac rhythm. So with setting sensitivity, you're going to determine the sensitivity threshold for each chamber as appropriate. Then you'll gradually turn the sensitivity dial, which is the very bottom dial, counterclockwise or to a higher numeric value. And you're going to observe the pace indicator light for flashing. You will slowly turn the sensitivity dial then clockwise or to lower the numeric value until the sense indicator light flashes with each complex and the pace indicator light stops. So this value is your sensing threshold. Then set the sensitivity dial to a number that was half the sensing threshold to provide a 2-1 safety margin. So you should assess the cardiac rhythm for appropriate function. Capture, is there QRS complex for every ventricular pacing spike? Is there a P wave for every atrial spike? Is the rate at or above the pacemaker rate if in demand mode? And does the sensitivity light indicate that every QRS complex is being sensed? So what exactly is demand pacing? So the clinician sets the sensitivity so that the pacemaker only generates pacing when the patient's own heart rate fails to do so after a set interval of time. So they'll set like the rate at 60. So if the patient is 45, we'll see pacing spikes. If the patient's 70, we won't see pacing spikes. If there's a lack of intrinsic activity, then the pacemaker demands help. That, a lack of intrinsic activity demands the pacemaker's help. So PVCs and PJCs are interpreted correctly as intrinsic activity in the patients who have the pacemaker, so it won't fire inappropriately. Asynchronous pacing, the sensitivity is set so that the pacemaker cannot see intrinsic cardiac activity and delivers milliamps or output at a set rate, whether the patient is asystolic or they have a cardiac rhythm that is intrinsically generated. This can be dangerous though, because the pacemaker may fire on T waves, which could cause the patient to go into the fib. Pacemakers are almost always, I'd say 90% of the time, set in the demand mode. AV interval, or ventricular delay. This is a delay in your ventricular pacing. It's programmed in the pacemaker after an atrial impulse. It's generated either by the patient's heart or after atrial pacing and capture when pacing is required. The AV interval, it's important to note, it's only available, of course, with the dual chamber pacing. It's actually similar to the PR interval, which is normally 0.12 to 0.20 seconds. Commonly, the AV interval is set at 150 milliseconds or 0.15 seconds. After this delay, the pacemaker will send out a pacing stimulus to the ventricle if the heart has not generated a contraction on its own. A rule of thumb is to set the AV interval slightly longer than the patient's PR interval, if they have one, to provide the opportunity for the patient's ventricle to function on its own. This is not always feasible if the patient's PR interval is very prolonged. Fusion beats, there will be times when the pacemaker initiates pacing at the same time the patient initiates their own cardiac activity. So on an EKG tracing, the paced beat will look different than if the patient generated their own cardiac activity, and it will look different than the other paced. It's going to actually be a blend of your paced beat and of your intrinsic beat. Transcutaneous pacing, like we said, it's generally emergent. It only paces the ventricle. It requires you to set both the rate and the output, and until you set the output, because automatically our defibrillators default to a rate of 0, it won't do anything. So often defaults to demand mode. So this means the sensitivity is set to native cardiac activity. So it will only pace when it's needed. In an emergency, set the rate between 100 to 80. All right, are you awake? So, turn up the current until you obtain capture with your transcutaneous pacing. It's not uncommon with transcutaneous pacing to kind of need bigger voltage or more output because you're having to go through the whole entire chest. So you will turn up those MAs until you see those spikes, and you see those spikes in the appropriate spot. So let's say you turned it up and it's on 50. And you have spikes, but they're not in the appropriate spot, turn it up to 60. If that's not right, turn it up to 70. Because you're pacing through the skin, like I said, you're going to need much higher than epicardial, you're going to need much higher than transvenous, you're going to need much higher than transthoracic. The bigger the patient, the more MAs you're going to need.
Pacemaker stimulation threshold. The importance of this is to make sure that the tissue that the pacemaker leads are attached to are able to be stimulated to cause a contraction. We're going to demonstrate how to do this. First of all, you have a patient whose heart rate is low. We need to increase it. We're going to turn on our pacemaker. With this, you need to increase your rate until the pacemaker has 1-to-1 capture. I'm going to go up to about 75. With this stimulation, I need to increase my milliamps to get that 1-to-1 capture. due to this being an external machine. I now have one-to-one capture, and that is by increasing my rate. To be able to do your stimulation threshold, I now need to decrease my milliamps until I lose that one-to-one capture. So we're going to decrease our milliamps, and I've lost one-to-one capture. You can see the spikes with no contraction after it. So that means I have lost that stimulation. What we need to do next is to increase our milliamps until we regain that one-to-one capture. So I'm going to keep going up with my milliamps. Remember, this is an external device, so your milliamps are going to be a lot higher than what they are if you have a transvenous. I now have one-to-one capture. This would be the number that I would look for my stimulation threshold. This number is 65, but let's say that in an external or for a transvenous, it really is 6.5. I need to multiply that by either 2 or 3, depending on what your policy is for your facility. With us, we're going to do it times 2, so that would be 13 that I would need to be put at. That's high, really, but when you're doing this device, it's going to be higher than normal. You then need to take and set your milliamps at what you need it at, and then you need to decrease your rate back to what it should be. Now with your internal devices that you use, the transvenous, this is going to be your rate. You're going to set that 10 or so above to get the one-to-one capture, and you're going to tell by the lights blinking if that's going to be one-to-one capture, and you can see it as we do here. This is your milliamp button that you will increase and decrease to figure out where your threshold is. If it was 2, I need to set it to about 4 or 5 for my patients, so that way they make sure that the tissue is stimulated and you have good contraction or reaction from that. And then make sure to close up your pacemaker.
So this is actually, the video is actually of a LifePak 12, which is very similar to our LifePak 20. If you look at this defibrillator, the buttons are exactly the same. Our dial's not that big. So in order to turn the pacer on, first you would turn the unit on, which is that green button at the very top. And if you look on the actual device, you can see a green box at the bottom. So what you would do is hit the pacer button, so you'll see that little green light that's in the button come on. Turn your rate to where you want it to be, and then where it says current, that is milliamps, so it's automatically on 0. You have to increase that in order to start pacing the patient. Once capture is obtained, you should slightly increase your MA to provide an adequate safety margin. This allows pacing with capture to continue should the patient's condition change. Transvenous, transthoracic, and epicardial temporary pacemakers, set your rate to 80 to 100 beats per minute. Then you're going to turn your MAs up until you have capture. Sometimes in emergency, the output is turned to the maximum number of milliamps to obtain capture quickly. And the sensitivity should be set. Setting the sensitivity at 2 or 3 millivolts in an emergency will be adequate to sense intrinsic cardiac activity. There is actually on the pacemaker a button that says emergency. Emergency pacing involves only the ventricle, as the goal is to obtain cardiac output quickly. So our pacemaker generator Medtronic product actually does have this emergency button. It's bright red. and when it's depressed, it will put the pacemaker on at a predetermined default setting. And it does, if you remember, it does asynchronous pacing. So if you remember earlier what we talked about, demand mode is much more preferred. Once your patient is stable, alternative pacing parameters may be ordered specifically for the patient. Sensitivity and stimulation thresholds can also be done once the patient stabilizes, but should not be done until then. Non-emergent pacemaker settings, whether pacing the atrium, ventricle, or both chambers, may be directed by the physician or dictated by a specific policy or procedure at your organization, which I do not believe that we have such a policy in place. So usually it will be your cardiologist or your cardiac surgeon who is telling you what settings they want it to be on. I can tell you, usually with epicardial wires, what I see the outputs on is usually 10, and with the transvenous, it's much smaller than that, anywhere from 2 to 5. Often the physician will indicate the desired settings as it says there, and usually that is most always the case. So this has been a screencast on temporary pacing. If you have any questions or would actually like to get your hands on the transvenous pacer or on the transcutaneous pacer, the defibrillator, please give me a call. I will be more than glad to help you or assist you in your development any way that I can. Thank you.